Hello, assalamu alaikum. What's up? Likely to discuss about a new way of learning, new, new way of learning, new things in a new manner, in a new way, in a new fix up. Okay, so telling about what? Telling about amphetamine intoxication. First of all, you have to look at these important talks like agitation, insomnia, psychosis. Patient has agitation, insomnia, psychosis, change in behavior like stealing money, and signs and symptoms of hyperactivity. And signs and symptoms of hyperactivity. There is signs and symptoms of hyperactive, sympathetic hyperactivity, like mydriasis, tachycardia, hypertension, and diaphoresis. Tachycardia, hypertension, and diaphoresis, with subsequent return to baseline following an observed period from abstinence are consistent with amphetamine. So, for amphetamine intoxication, A for agitation, P for psychosis, A for agitation, P for psychosis. There may be H for hypertension. There may be diaphoresis. There may be diaphoresis. There may be behavioral changes. These things has to present for a diagnosis of amphetamine intoxication is clinically positive toxicology test can screen and can be supportive positive test positive test positive toxicology screen can be supportive. However, decongestant the decongestant pseudoephedrine and antidepressant bupropion and silazolin can cause false positive for positives on amphetamine on urine toxicology testing. Amphetamine include a range of substances from those prescribed for the treatment of ADHD to the newer synthetic cathinones like bath salt which are not detectable on routine toxicology screen. Amphetamine intoxication can present with psychiatric symptoms irritability, agitation, and psychosis. Common physical signs include tachycardia, and hypertension. So, on opioid withdrawal syndrome, what happens in opioid withdrawal syndrome? There is muscle spasm, joint pain, nausea and vomiting, diarrhea, abdominal cramp, rhinorrhea, lacrimation and sweating, irritability, hypertension, mydriasis may occur. However, delusions are unlikely, and symptoms of opioid withdrawal often three to five days. Last 3 to 5 days. That's all. Okay. Came with new stem. Like 24-year-old man is brought to the emergency department. The patient is discharged and returned to work without issue. Which of the following is the most likely diagnosis? He attempted to barricade himself in the garage 3 weeks ago while working at the construction site. 3 weeks ago, while working at the construction site, the patient was almost hit by a falling metal beam. Since the accident, he has become increasingly distressed and believes his supervisor arranged for the beam to deliberately hit him. Earlier today, the patient received a routine work email and is not convinced that it contains and is now convinced with it contains a hidden message and warning that his life is still in danger. He used cannabis and cocaine intermittently in school and but has not used either drug for the past years. The patient has no prior medical or psychiatric conditions. The patient appears hyper vigilant and becomes agitated when hospital admission is discussed but calms down after having conversation with his wife. The patient agrees with hospitalization and once admitted he refuses to take medication. After admission he refuses to take medication. The condition improves over the course of several days without any pharmacotherapy. The patient is discharged and returned to work without an issue. This is brief psychotic feature. What happens in brief psychotic feature? More than 1 day, less than 1 month, sudden onset, full return to function, sudden onset, full return to function. More than one psychotic symptom, delusion, hallucination, disorganized speech, delusion, hallucination, disorganized speech, and grossly disorganized or catatonic behavior, grossly disorganized or catatonic behavior lasting more than 1 day, less than 1 month, lasting more than 1 day, less than 1 month, with full return to functioning, and is consistent with brief psychotic disorder. So yes, some sort of incident happen, and then he starts thinking that everything becomes normal without any treatment. So it is brief psychotic disorder. More than one psychotic symptom, delusion, hallucination, disorganized speech, grossly disorganized or catatonic, grossly disorganized or catatonic behavior, lasting 1 day, less than 1 month, with full return to functioning, is consistent with brief psychotic disorder. As in this case, what happens in so psychotic feature more than one or more than one psychosis, more than 1 days, less than 1 month, sudden onset, full return to functioning. This is BPD, rule of 111, rule of 111. In schizophrenic disorder, more than 1 month, less than 6 months, more than 1 month, less than 6 months of same symptoms such as schizophrenia and functional decline not required. Functional decline not required. In schizophrenia, it requires functional decline. So, functional decline not required in schizophrenic disorder and functional decline requires in schizophrenia disorder. More than 6 months, one more than 1 month of active symptom can include more than 1 month of active symptoms can include prodromal and residual period. And schizoaffective disorder, Mood episode with concurrent active phase symptom. Mood episode with concurrent active phase symptoms of schizophrenia, plus more than 2 weeks of delusion or hallucination in the absence of prominent measure. Episodes with concurrent active phase of schizophrenia with more than 2 weeks of delusion or hallucination in the absence of mood symptom. Delusional disorder, more than one delusion, more than 1 month with no other psychotic feature. No other psychotic symptom. So more than one delusion, more than 1 month, no psychotic symptom. Delusional disorder. More than 1 day, less than 1 month, had psychotic symptom is brief psychotic disorder. In brief psychotic disorder, there is psychotic symptom, and delusional disorder, there is no psychotic symptom. No psychotic symptom. So, this 24-year-old man, whenever he was brought to the ED 3 weeks ago, construction work site, he was almost hit by a falling beam. Since then, he starts thinking that his supervisor is trying to kill him. When he found a message after getting the email, he starts thinking that, or there is some sort of hidden message saying that his life is in a danger. His life is in a danger. So that's why he becomes hyper vigilant and becomes agitated, and hospital admission is discussed but comes down after having conversation with wife. This is BPD. Okay. 40-year-old man with a history of hypertension comes to the office for checkup. The patient has been under lots of stress due to some work issues and marital problems. He says, "My wife is always criticizing me. We fight a lot. Last week she was angry that I didn't make it to my daughter's basketball game. I wanted to go, but it was too tired. It was too tired because mm, I had stayed out late with friends from the night before. A man has to relax sometimes. He consumes 5 to 6 alcoholic drinks. The physician previously explained that the patient's hypertension is worsened by alcohol use, and the abnormal tests are likely due to alcohol use. But the patient remains unconcerned. Most appropriate initiating discussion. Although you enjoy drinking, do you think it may have played a role in missing your daughter's unhealthy alcohol use? Patients' level of awareness and the motivation to change. Motivational interviews, substance use disorder, and other behavior who are not ready to other behavioral in patients who are not ready to change. Acknowledge resistance to change. Address discrepancies. Address discrepancies. Says my wife is off. Address discrepancies between behavior and long-term goals. Enhance motivation to change, and non-judgmental. These are the things you have to remember. You should not be judgmental. You have to enhance motivation to change, acknowledge resistance to change, acknowledge resistance to change. You have to acknowledge the resistance to change, and techniques is OARS, open-ended questions, give affirmations, reflex, and summarize. Open-ended questions, open-ended questions, give affirmation, reflex and summarize, reflex and summarize. This is all about motivational interviewing. Okay, 59 opioid prescribing best practice. 59-year-old man comes to the office to follow up for chronic back pain. His pain level has decreased from 8 to 3 on a scale of 0 to 10. Pain is no longer interferes with activities of daily living. The patient has no drowsiness, constipation, or nausea. Other medications include naproxen, acetaminophen, and lidocaine patch as needed. Temperature is 37 degrees Celsius. Pulse is 114 by 76. Pulse is 64 per minute. Respiration is 12 per minute. On examination, the back has a greater range of motion. The back has a greater range of motion than it did during the last visit. Which of the following would be most helpful in the early detection and prescription of opioid misuse? Why opioid is misuse? Querying the prescription drug monitoring database. Querying the prescription drug monitoring database in each visit. Opioids accounts for three-quarters of all fatal prescription drug overdoses. Early identification of misuse is critical and in ensuring patient safety. Opioid misuse is defined as opioid misuse is defined as the medication in a way that deviates from the manner and purpose for which it is prescribed. Why we have prescribing for easing the pain, for decreasing the pain. So misuse means we are out of our purpose. Uh, Obtaining opioids from multiple prescribers, taking non-prescribed opioids concurrently, using recreational drug and other non-prescribed controlled drugs. The PDMD prescription drug monitoring program is a helpful tool for detecting misuse. For detecting misuse, the state specific protein drug misuse program has obtained dates the prescription are filled and prescriber's information. The PDMP can identify the patient who are receiving opioids from multiple prescribers, suggesting possible overuse or diversion. The database should be queried because each refill Tick tock, tick tock, clock is ticking. Okay, moving on with the motivational interviews, engaging, focusing, and evoking. Engaging, focusing, and evoking. 46-year-old man comes to the office for follow-up. The patient asks on a scale. The physician asks the patient on a scale of 0 to 5. That 5 is the highest. How ready are you right now to make a change in the dream? He gives the patient rates her readiness about 2. So, what makes you rating 2 rather than 0? Engaging is non-judgmental, open-ended question, collaborate to set the agenda and elicit patient's strength. Ask the patient to identify one or two behavioral targets, evoking elicit change to get patients' commitment and reasons to change. Then, when the physician reports evoking change, talking motivational interview asks after asking the patient to assign only written value. to her level of readiness. On a scale of 0 to 5, 5 is the highest. The physician asks an open-ended question to explore her personal motivations to change. Although this patient reports relatively low readiness about two, she does not regret it. She does not rate it a zero. A good starting point is to help her identify she why she states it why she states it too. For example, at the point the patient reasons for a rating might include a desire to avoid another hospitalization, fear of losing job, or concern about the effect of her training on a relationship. From her perspective, these reasons might outweigh the special health risk of pancreatitis. In addition to educating the patient about pancreatitis, focusing on her internal motivation is the key to promoting change. It's the key to promoting change. Okay. 80-year-old man is brought to the office by her husband with health disturbance. He is in Alzheimer's. He has a history of Alzheimer's disease. For the past month, he has behavioral problem Alzheimer. Medication is amlodipine and donepezil. Blood cell counts in serum electrolyte are less than normal. Caregiver education is provided, and mildly risperidone is started after discussing medication options. A week later, the husband reports that the patient is less aggressive, but restlessness and wandering has worsened. Restlessness, his aggressiveness is down, but restlessness and wandering has worsened. He is on amlodipine and donepezil. Risperidone started after discussing what should be added. After starting akathisia, risperidone. Patient is restless, wandering, and unable to sit still. Restless, wandering, inability to stand still. The patient's worsening restlessness, wandering, and inability to sit still that developed a week after starting antipsychotic medication. His akathisia is a common extrapyramidal symptom. Patients with akathisia experience a sense of inner restlessness, wondering, and urge to move. Which of the following is internal agitation, especially in akathisia is more common in high potency antipsychotic risperidone and haloperidol, but it can occur in low potency. It can occur in low potency psychotics too. The first recommendation is dose reduction trial, or if no benefit discontinuation of the encounter, the beta blocker propanol benzodiazepine may be used. In alcohol use disorder, what is alcohol? Drinking a inability drinking a larger amount, inability to cut down cravings, drinking in hazardous situation, failure to fulfill role obligation, control, drinking despite health or psychological interpersonal problem, evidence of tolerance and withdrawal. Psychosocial treatment, motivational intervening, cognitive behavioral therapy, residential treatment or rehabilitation, individual help groups, Alcoholics Anonymous, naltrexone, acomprosate, and disulfiram. Acamprosate preferred in patients with liver disease and opioid use. So, alcoholic patient, prolonged history of heavy alcohol, hospitalized due to alcohol use. Sometimes alcohol. We know that one of the causes of pancreatitis is alcohol. Idiopathic is one of the cause called stone. Then alcohol is the cause. He has alcohol-induced pancreatitis. Vitals are normal. What you should give acamprosate. It is given in patients with liver disease or opioid use. Naltrexone can be used. Naltrexone is a new opioid antagonist is another first-line alcohol use disorder. However, it has been associated with hepatotoxicity, so unrelated patient with naltrexone is contraindicated in patient and with naltrexone is contraindicated in patient with uh, patient with liver disease, those who are taking prescribed opiate medication. So in alcohol use disorder, acomprosate, disulfiram, and naltrexone. Alcohol use disorder AND, acomprosate, naltrexone, and disulfiram. You know that a common question of psychosis regarding medication that is glucocorticoid induced psychotic effect. 58-year-old man is brought to the emergency department by his wife for unusual behavior. She says that since last night the patient has been afraid to go out into the bedroom because she sees evil children there. She spent most of the night packing back and forth in the living room and got minimal sleep. 5 days ago, when the patient has asthma exacerbation and primary care physician added a new oral medication, he says that 5 days ago has an asthma exacerbation and his physical and his primary care physician added oral medication. Medical history includes hypertension, non-insulin, diabetes. Patient does not use alcohol. Vital signs, physical examination are within the normal limit. The patient is alert, aware of the surroundings. He reports hearing of children laughing at him. This patient exhibit acute onset psychosis, temporary acute onset psychosis, high dose that is for high dose glucocorticoid for asthma exacerbation. His psychosis does not appear to be associated with delirium. He is alert and oriented. Is alert and oriented, and or any other psychiatric medical is alert and oriented. Okay, that's all. Thank you.